Welcome, everyone, to Misconceptions. I am so honored and just so thankful that Dr. Rachel Weinerman agreed to meet with me today to talk about a topic that is really something that I feel like I'm hearing more and more about. I heard you present at a conference a couple of weeks ago now, and first of all, your presentation was fabulous, so thank you. And I want to review this content. You talked about PCOS. And we're going to get into the meat of what is PCOS and how does it affect women, and so much of it relating to hormones. But I think that this is a conversation that really all women need to hear. So, Dr. Wienerman, thank you for joining me.
Thank you so much. It is such a pleasure to be here.
I'm going to ask if you could tell us a little bit about yourself before we get into the conversation around PCOS.
Great. Well, it was also a pleasure meeting you at the conference. We had many great conversations about women's health, and I'm so excited to be here today. So, I am a reproductive endocrinology and infertility physician. And this means that I have completed medical school, which I did at Harvard Medical School. And then I did a 4-year OBGYN residency at NYU, and then a 3-year fellowship training, which then trains me to be a reproductive endocrinology and infertility physician. And I did that at the University of Pennsylvania. And now I'm an associate professor at Case Western Reserve University in Cleveland, affiliated with University Hospitals. And my practice involves both treating women and couples who have difficulty conceiving or continuing a pregnancy. That's the infertility component. And then I also see women who have a host of reproductive issues. That's the reproductive endocrinology component. And PCOS really straddles both of those
I see
titles.
that.
So it's a
Right.
reproductive issue that, as we'll talk about, affects women in all aspects of their life and all ages, but it does have a very specific impact on infertility.
So I love how you just opened that conversation. First of all, I didn't even realize you were in my backyard. I live in Philadelphia, so I had no idea that you had been at Penn at a time. I think that what you just opened up that conversation around, it's not just in order to get pregnant or not to get pregnant. So why don't we start with an explanation of what is PCOS?
Yeah, that's a great question. So I would say my general way that I help people understand PCOS is that polycystic ovary syndrome, which is what it's named, is a horrible representation of what PCOS actually is. PCOS is a hormonal imbalance. It is a problem of the brain talking to the ovary. And that hormonal imbalance results in all of the things that happen to a person who has PCOS. So if I were to rename PCOS, I would call it metabolic syndrome of the ovary. And that really gets to the fact that it's actually a hormonal imbalance that affects your metabolism, and that results in irregular periods, which can affect a woman's fertility. But it's really that metabolic imbalance, that hormonal imbalance, that really is responsible for all the other things that happen with PCOS.
So when we hear the word metabolic syndrome thrown quite a bit more recently, I remember hearing the term maybe 10, 15 years ago and kind of going, it's just like amorphous idea. What are we defining as, I'm here just as a refresher for me, what is metabolic syndrome today? How are we defining that?
So, metabolic syndrome is something that can affect anyone, it can affect men. Or women. And it really is a problem that manifests as problems with blood pressure, problems with weight, and it can also veer into what we call diabetes or insulin resistance. So
Okay.
metabolic syndrome, um, it actually represents the fact that all of those things that I just mentioned, high blood pressure, being overweight, and having either insulin resistance or diabetes, are all connected. So
Okay.
when I say metabolic syndrome of the ovary, PCOS is a very specific way that metabolic problems that affect weight and the way our bodies process sugar, we call that insulin resistance, has an impact on that communication between the brain and the ovary, that it can impact a woman's menstrual cycle.
And would we see metabolic syndrome just as a category or definition referring to other hormonal influences? Like, do we see that, or it's really just in the specific areas that you just described?
So it is really about
Okay.
cardiac health, and there's a lot of hormones that go into how we process sugar.
Okay.
So that term insulin resistance really, there's a lot of things that go into that. Um, The only other thing I'd mention that goes into metabolic syndrome is high cholesterol. So a problem with the way your body processes fats and lipids. So that all is what's accompanied into metabolic syndrome.
So I'm curious, and I know this is kind of like one step to the side, knowing, and this is not necessarily the conversation for today, but I know that we are hearing so much about the semaglutide. I know I pronounced that improperly, but the medications like Ozempic and Wegovy and things like that, the Zepbound, these new medications that are impacting hormonal, kind of functioning in our body, also specifically related to like insulin resistance, right? Like there's that connection that's happening there. Is that all part of addressing metabolic syndrome? Like, are those medications directly targeting that concern?
So I would say the answer to that question is definitely yes.
Okay.
So when we have struggled with obesity as a population for many, many years, and that battle is nowhere near being over. There's so many reasons why people struggle with obesity on a large scale. It's not just individuals, it's us as a population that are struggling with it. These types of medications, which we generally put into the category of GLP-1 agonists, and there are different types of these medications. They are one of the first obesity medications that actually targets one of the sources of metabolic syndrome, which is insulin resistance. So they don't actually target insulin directly, they target another class of hormones, but that actually plays a significant role in how our body processes sugar via the hormone insulin. So this is a very what I call smart class of medications. It really targets the root cause of what causes obesity for a lot of people, which has to do with the way our body processes sugar and has to do with how our metabolism works. So yes, I would say this general class of medications is very effective in targeting some of the root causes of metabolic syndrome.
So this is something that possibly over long term will also be targeting issues of PCOS, meaning like the fallout could potentially be something where the solution or the treatment may involve some of these medications to kind of work on those systems as well, right? If we're calling it metabolic syndrome of the ovaries, would that be an accurate description?
Yes. And I think that if you were going to ask me as a researcher, which I do clinical research, I do translational research. So as a researcher interested in PCOS, if you were to ask me today, what is the main area of focus for PCOS research, say over the next 5 years? I would say the role of GLP-1 agonists and medications like it in the treatment of PCOS is the area that I would focus on.
Okay, fascinating.
Because we do see that PCOS involves many of these factors that I just mentioned with metabolic syndrome, and treating those with a GLP-1 agonist can alleviate many of the symptoms that patients have with PCOS. Not all of them. There's actually other things, and we'll get into those, but some of those. And especially if obesity is a component of the patient's PCOS, then targeting insulin resistance and obesity at the same time can be a very effective treatment.
Okay, fabulous. All right. So let's think about, let's break this down for somebody who has no idea what we're talking about. Let's explain, how does PCOS present? And then if we can also then talk about how it impacts fertility.
Yeah. So first of all, as you heard me say, I don't like the term PCOS, polycystic ovary syndrome, has really nothing to do with cysts in the ovaries. So polycystic ovary syndrome is a condition that presents often with the reproductive issues that it causes. So PCOS can present with irregular periods. That's one of the diagnostic criteria. And we define irregular periods typically as a period cycle that's longer than usual. So typical period might be, say, every 28 days. A patient with PCOS might not get a period for longer than every 35 days. So, 1 month it might come normally, the next month it might take 60 days, 40 days. So you can have shorter cycles, but I would say the typical PCOS patient has cycles that are irregular, doesn't get them as often as a typical patient without PCOS. So that's one. The other thing that we see is extra hair growth. And that's typically in places associated with male pattern hair growth, and that's specifically associated with high testosterone levels. So patients with PCOS will have hair on their chin, sideburns, that can be on their chest or abdomen. And sometimes the hair growth is so significant that women need to shave daily or find other means to remove that hair because it can be very unpleasant for the patient. And then the third criteria that we see, and this is really where it gets into that polycystic ovary term, are lots of follicles in the ovary. Now, for those of you who are unfamiliar with that term, follicles are little fluid-filled sacs that contain eggs. So every woman has all the eggs that she's ever going to be born with at the time of birth. And every month, a group of these eggs are ready to be ovulated. Women with PCOS have more of them each month because of this hormonal balance. They don't undergo the same process that we call atresia. And it's interesting. It's having all of these follicles in the ovary is what gives rise to that name, polycystic ovary syndrome. So I don't like the term cyst because they're not cysts. They're actually normal. They're just little tiny follicles. It's just a lot of them. And having all of those follicles can actually contribute to problems with ovulation. So that's how PCOS presents. So irregular periods, extra hair growth, lots of follicles in the ovary, and those are our diagnostic criteria. It can also be accompanied by being overweight, obesity. Some women have either diabetes or prediabetes. It can also be accompanied by mental health issues. So a lot of women with PCOS suffer from anxiety and depression. It can be associated with sexual dysfunction, specifically low sex drive, or what we call low libido, often accompanies PCOS. And because of the menstrual cycle irregularities, it can also cause infertility.
So one question I have for you, when you say we have multiple follicles, if you're trying to stimulate someone to produce, to stimulate them so that we can do a retrieval or to pursue treatment for infertility, a lot of follicles sounds like a good idea, right? So how is it that the hyperstimulation or the quantity of follicles is not a good thing for women that have PCOS?
Great question. And I do tell patients who are undergoing specifically IVF that sometimes PCOS can be a little bit of a superpower because you do overproduce follicles. That actually is one of the problems in PCOS. So let me go back to my original formulation for what PCOS is. It's a hormonal imbalance where the brain and the ovary don't talk to each other. Why is that? So the main thing that I would say is that women with PCOS produce too much testosterone from the ovaries. That extra testosterone does two things. It makes the woman have the extra hair growth, which can be very bothersome. It also confuses the brain. And I'm talking in layman's terms here. You want to get into more medical, we can get into more of those details.
This is good.
But the high testosterone, it confuses the brain. The brain does not understand the message it's getting. And as a result, sends back a message to the ovary that is not correct. And so when you have this miscommunication between the brain and the ovary, you're not getting the hormonal stimulation that you typically need to grow one single dominant follicle that will then go on to ovulate.
Okay.
So instead, you're getting this imbalance of hormones that causes lots of little follicles to stay in the ovary, but no one follicle to lead the pack, grow bigger, and ovulate.
Which is what would happen under a normal healthy woman's cycle. One egg is produced every month. Hopefully, one egg is produced every time in order to produce a healthy potential pregnancy, baby, etc.
Exactly. So what ends up happening in PCOS is you have all these follicles, which, as you said, hey, that's a great thing. The problem is having all those follicles can actually contribute to that miscommunication between the brain and the ovary. The ovary is just sending the wrong signals, the brain is sending the wrong signals, and then what ends up happening is you just don't ovulate. And the lack of ovulation is what is contributing to the irregular periods.
Got it. And so when you say it's a superpower, just to explain to those that might not understand what you mean by that, but if we're trying to stimulate the ovary to produce a lot of follicles, having them already there and then helping them, many of them mature enough for retrieval would be very valuable for somebody who's going through IVF treatment.
Exactly. And IVF is in vitro fertilization, which is a very powerful tool that we have in the world of reproductive endocrinology and infertility, where we can actually stimulate someone to grow as many eggs as possible in 1 month, physically take those eggs out of the body, and then either freeze them for future use or fertilize and make embryos to help somebody conceive. And IVF with PCOS can often be very successful because of how many follicles we have. Now, I will say one small caveat, and then we can either get into that now or wait till later, that there are some challenges with IVF in PCOS patients, and one of those is egg quality. So even though we might have a lot of eggs, that hormonal imbalance still exists and can sometimes actually result in fewer high-quality eggs or fewer high-quality embryos.
Oh, interesting. And so is that something that's impacted? Can we impact really can I mean, I guess like kind of answer my own question, but can you impact the quality of those eggs via hormonal manipulation, or at that point it's already kind of done? Like when you're
There
doing
are some
IVF?
limited ways that we can, but I would say my general approach to IVF and somebody with PCOS mimics my general approach to PCOS in general, which we can talk about, is how do we help a woman restore that hormonal imbalance, both to have normal ovulation, normal menstrual cycle function, and if we're talking about IVF, to get better egg quality.
Okay, it's interesting. So, all right, let's talk. So, tell me a little bit about from a treatment perspective. Well, yes, from a treatment perspective, what are some of the treatments that are available for women that have PCOS? And I guess maybe starting when we're not dealing exclusively with fertility. So, there are other implications you mentioned. There's cardiac potentially, and there's insulin resistance and obesity. There's issues that somebody who may have no desire to conceive a pregnancy would go to an REI to discuss and say, like, this is a problem. What are some of the things, first of all, what would prompt someone to come into treatment? Like, what should someone who has known or suspected PCOS, what are they considering in terms of going in for consultation or treatment?
So, first of all, I would say that somebody with PCOS should seek medical attention. And the way that they might know that they have PCOS is that their periods are irregular. That's often the first sign. Now, irregular periods can be caused by a lot of things. PCOS happens to be one of the most common, but there are other reasons. So I would say if someone is not getting a period regularly, it is a reason to go to a physician, because that fact that the woman is not getting regular periods could be a sign that something else is going on.
I'm just
Um,
curious, at
with
what age would you suggest that? Because I know that,
so
like, I
I
remember speaking to
yeah,
pediatricians and they're like, it's normal to have irregular cycles for several years in their teenage years. What's your opinion on that?
I think that is true. I think 3 to 4 years after someone gets a period, we expect them to be irregular. Now, if a girl gets a period and never gets a period again for another 2 years, I'd say probably also worth a trip to the pediatrician, but irregular periods for the first few years after what we call menarche or first period is normal. So
Okay.
let's say we're talking, 4 or 5 years out from somebody getting her first period.
Okay.
That's when it's worth a trip. Now, if there are other signs of PCOS even earlier, that could also be worth an evaluation. So other signs to look for besides irregular periods would be that hair growth, or severe acne. So if a woman is getting really difficult to control acne, especially if that acne is on places other than her face. So if she's getting chest acne or back acne, that could be a reason to seek medical attention, and not just from a dermatologist, because if there's a hormonal reason, it's not going to be treated by skin or topical treatments alone. If somebody has obesity that is very difficult to control or has prediabetes associated with one of those other symptoms, that could also be a reason to specifically see somebody who specializes in PCOS.
Okay, fascinating. Because I don't want everybody running to their pediatricians when their kids are 14 with their regular periods. I want to consider
That is
that.
a very good point. And definitely, pediatricians are very well versed, in my experience, with understanding what's a normal pattern and what's
Mhm.
abnormal. So I definitely would advise patients to listen to their pediatricians in terms of when to seek an additional consultation.
Okay. So once we have a young woman who has noticing some of these symptoms and they make a consultation with you, most likely, well, hopefully with a somebody who specializes in hormones and specifically in PCOS, what are some of the things you're looking at from a treatment perspective?
So, first of all, I would say that because PCOS is a metabolic condition, the very first thing that we talk about are metabolic solutions. So, somebody who's coming to see me who doesn't necessarily want to get pregnant, but she is bothered by her irregular periods, her extra hair growth, weight gain, maybe she's suffering from anxiety and depression, just overall, not feeling good. How can we help her? And the very first thing is, well, I'll put it to you this way. I fully believe with PCOS patients that knowledge is power. And I really think that a lot of treatment for PCOS begins by understanding what PCOS is and how to address it. So if someone comes to me and doesn't know that she has PCOS, or maybe she's been told that she has PCOS, but she doesn't understand what that is, the very first thing that we do is have exactly the conversation that we just had. What
Mhm.
is PCOS? Why does it happen? Once you understand that, then the treatments begin to make sense. So if PCOS is a hormonal imbalance that's caused by a disruption in the brain and the ovary talking to each other. And we didn't get into this before, but a lot of that is caused by insulin resistance. So we talked about the fact that the ovary makes too much testosterone. Why? One of the big reasons is high levels of insulin, which is the hormone that the body uses to process sugar, actually causes the ovary to produce more testosterone. So there's a direct result. So if we're targeting insulin resistance as a means of lowering testosterone and restoring communication between the brain and the ovary, the ways we know how to do that are diet and exercise.
Which nobody really
So
wants to hear. I gotta be honest with you. It's one of the hardest things around, I think, about the treatment of this issue. So tell me a little bit more about that.
nobody wants to hear that. But again, I think if you understand the role that sugar plays in PCOS, it makes a lot more sense why you have to make some lifestyle changes. So, insulin resistance is essentially a condition where the body can't handle sugar. And every time you eat sugar, and that means not just added sugar, but processed carbohydrates like white flour, white rice, white bread, every time you eat that, your body has to make insulin to get the sugar where it needs to go in your body. And if your insulin is not working well, which happens in insulin resistance or prediabetes, then the body has to make more insulin to get the sugar where it has to go. The body is going to work really, really hard to get that sugar to where it needs to go. And because it's making more insulin, now you have higher than normal insulin levels. And that insulin is going to travel and do all the things that we just talked about with the ovary and the brain. So if you're going to focus on insulin resistance as the problem, the solution really is two things. One is dietary changes, because dietary changes, you have direct control over how much insulin your body is going to make. The second is exercise, because exercise actually helps your body process insulin. So the dietary changes that we can make are to switch all of our carbs to brown. Whole wheat and high fiber are harder for the body to digest. They're slower and they cause fewer insulin spikes. The second is to try to reduce added sugar in our diets. And then the third is really just to focus on healthier foods like fruit, vegetables, healthy proteins, and fats, and trying to minimize our overall intake of carbohydrates while choosing healthy carbs when we are going to have carbohydrates.
What's interesting to me is the way that you're presenting this is a little bit more of a scientific bend than what I feel like has been historically kind of sold to women who are struggling to get pregnant is like, listen, you just need to lose weight. And if you lose weight, then hopefully you'll be able to get pregnant more easily, a lower risk of lowering your risk of miscarriage, higher risk of conception. But the way that you just explained it kind of flips it into a little bit more of a science experiment. Like if the food that you're eating is going to reduce your insulin it is going to reduce your insulin production. And that is going to directly correlate to the possibility of ovulation and meaning lowering your weight. But even if I don't talk about it well, let me ask you like this. Is it just about weight? Or if the food that I'm choosing to eat is the food choices and changes enough to impact change, or it actually has to be a specific number on the scale in terms of reducing body fat?
Such a great question. And I've actually changed my thinking about this over the past 10 years that I've been in practice. So if you asked me this question 10 years ago, I would say, oh, the literature is very clear. You lose weight, PCOS improves. I've stopped using that formulation in my counseling because ultimately, as a woman, I have very little control over my weight. I know that sounds crazy to say, but I do. And a lot of times my patients with PCOS tell me, look, I eat the same food that my friend eats. She gains 2 pounds. I mean, I gain 2 pounds and she doesn't. Why?
Right.
And it's
Right.
because of this hormonal imbalance. So I can't control what's on the scale, but I can control what I eat. And I
Right.
can control if I'm exercising. So I really focus less on the weight than on the things that I can control, which is what I'm eating and how I'm eating. Now, notice I didn't say how much. So I really don't think it's about reducing as much as it is about choosing smart foods for your body. So I really appreciate that question because I think it is actually very important to me. I don't talk about weight as much as I talk about making healthy choices.
Right. And that the healthy choices, I think that it also really makes a very big difference in terms of the brain for the patient. And I'm talking from an emotional wellness perspective, right? That because people who have PCOS, I think in general have a very difficult time losing weight. Like it is something that's a little bit more complicated. At least that's my understanding, is that it is harder for women who have PCOS, who have, insulin sensitivity, that weight loss looks different for them. And so changing into a bit of more about the science of what you're doing in terms of what you're putting in and the internal changes that happen when we do that, I think it feels a little bit more empowering than shaming. And that's one of the things that, I mean, I see on a lot of the listservs around, like, I'm looking for a recommendation or a referral for an RE that is, not fat shaming, right? And that's a big challenge that I think many women are struggling with, where the conversation doesn't sound like the one you and I just had. The conversation sounds like, listen, if you would just lose 10% of your body weight, 5% of your body weight, I think we'd have a greater chance at fertility, or greater chance of staying pregnant, or, getting you pregnant. Um, are you hearing that from women? Is it something that you're noticing as a trend in terms of women saying, like, don't make me focus on weight, but then really understanding it as a scientist, like how necessary it is to discuss this?
Yes, and I think talking about weight and obesity is so challenging because we have these dual ideals in society that, on the one hand, we know the impact of being overweight on certain health outcomes, and that includes fertility and pregnancy. On the other hand, we know that telling a woman just to lose weight is not going to be helpful. And we also know that it's very dangerous if you start telling people there's a specific body type that is ideal or that they should reach. I mean, that's not helpful to anybody. And so I really appreciate the body, the kind of, I live in your body and, be very happy with your body type of sentiment, because it is, you don't choose your genes, you don't choose how you look, you don't choose the body that you're given. And so I think it's really important to focus on how can we improve health rather than how can we improve weight. And for some women, losing weight will be a necessary part of achieving that health, but not every woman is going to achieve the same weight goals.
Mhm.
And that's where I think it's really important to be empowering to the patient. First of all, to acknowledge, yes, you have PCOS. Weight loss is going to be very challenging for you. And you're 100% right. Patients with PCOS really struggle to lose weight. And a lot of that is because their bodies are fighting them every step of the way. I actually often use an analogy in my counseling of patients that if you have PCOS and you're trying to lose weight, it is like you're trying to climb a mountain and somebody is just standing up there trying to push you down every step.
Ugh,
So,
it's so
like,
depressing.
yeah, or swing against a current. Like you
Mhm,
are working so hard just to maintain the weight that you're at.
mhm.
Losing weight could sound so impossible to somebody in that situation. So we do have a conversation about lifestyle factors before we even start talking about medicine for someone coming in with PCOS, but we also need to focus on the fact that lifestyle changes are not the end all and be all of PCOS. So
Right.
lifestyle factors are what I consider to be the scaffold or the platform, and then we build on that with medications. And that's where I really feel like PCOS is a partnership between physician and patient. I can provide the medical treatment, but it works best if the patient is bringing the lifestyle changes to the table.
And what are some of the medications that you would use? What kind of medication? What are the treatments typically beyond lifestyle changes that you have at your disposal?
So that really depends on the goals that the patient has. So let's say for the sake of our initial discussion, it's somebody who's not interested in getting pregnant, then we really focus on what are the problems that the woman is having and how can we address them. So if the woman is having, let's say weight is a primary concern for the patient, and she's not having enough success just with weight loss, with diet and exercise, or she's finding those to be really challenging, then metformin can be very helpful. Metformin is a diabetes medication, so it directly targets insulin resistance. I don't use it for every patient with PCOS, but I do use it for women who have evidence of prediabetes on their testing. I do use it for women who are what we consider to be obese and are struggling with diet and exercise alone. They don't feel like that's helping them enough. Or they don't necessarily want other hormonal management, then that metformin can be a very, very good tool. One of the mainstays of PCOS treatment is birth control pills.
Hmm.
And this can be very challenging for patients to hear. Some women are happy with it, but the experience that I have also is that a lot of women tell me, well, my OB put me on birth control pills and, kind of give that to me as a Band-Aid. Why are you giving me a pill to mask the problem? I don't want to mask the problem. I want to solve the problem.
Right.
So I think I do prescribe birth control pills a lot for PCOS, and we have to go through the rationale when we're talking about it. Birth control pills, which contain a combination of two hormones, estrogen and progesterone, are really an all-in-one treatment for PCOS. And the reason is because they help regulate periods while at the same time decreasing hormone production from the ovaries. So it actually stops the ovary from making testosterone. And it does one more thing. it actually raises the concentration of a very specific hormone called sex hormone binding globulin, which is just a fancy word, but it's a hormone that binds up testosterone. So it actually lowers testosterone in two ways. It raises this other hormone, so it binds up more of the testosterone in the blood, so you see less of the testosterone. And two, it actually reduces testosterone production. So that's why birth control pills can be very effective, because not only do they regulate the periods, which, by the way, is very helpful in preventing something called endometrial cancer that can happen if women don't get regular periods with PCOS.
Really?
And second is that it can really improve the hair growth. Some women actually have hair loss, which you didn't talk about, and acne. So that's why I really think that birth control pills are an all-in-one. But if women, for whatever reason, can't take a birth control pill, that's when we start thinking about other things like metformin. And then there's one final medication that I just want to tell you about, which is something called spironolactone, which is a testosterone blocker. So we often add that to the birth control pill if the symptoms are not well controlled, or if a woman can't take a birth control pill for whatever reason, that can also be an effective tool for hair growth management.
Okay. Now, one question that comes up for me, when you talk about reducing or eliminating even the testosterone production, obviously testosterone is needed because our body is supposed to be creating it. So what is its actual purpose in a woman's body? I think some women might even be surprised that we're even talking about us producing testosterone. It's like, isn't that the guy's hormone? So what are the implications of shutting down the production of testosterone completely?
Oh,
Or
great
are there any?
question. And it is often surprising. I talk about testosterone, and a lot of times we'll say, yeah, that is the hormone that is most associated with men, but women do produce small amounts of testosterone from their ovaries. And it's so interesting how even just a small increase or decrease in testosterone really can impact the way a woman feels. So too much testosterone, we get the hair growth and the acne that we talked about. Too little testosterone can impact a woman's sex drive. So that's probably the main complaint that I hear from birth control pills, is that it does lower testosterone that can impact a woman's libido. The interesting thing about PCOS is that women often have sexual dysfunction even at baseline. So they actually have sexual dysfunction or low libido even though they have elevations in testosterone. So for patients with PCOS, lowering that testosterone may not actually impact their sex drive as much as it does for other women.
Interesting. And is it just impacting sex drive? Does it impact ability to feel pleasure, to experience an orgasm? Is there anything like that that goes along with the reduction in having a overproduction of testosterone?
Typically, it's more associated with sex drive than it
Okay.
is with the ability to have an orgasm. But every woman obviously is different in terms of their sexual physiology. We do know that testosterone is important in ovulation. So for women who are trying to get pregnant, then we're trying not to eliminate testosterone entirely, because having some testosterone is important in having, going back to our original part of the question, good egg quality, for example, in IVF. And there are probably other roles, estrogen and testosterone and progesterone all play an impact in women's health. Testosterone can have an impact on metabolic health. That's one of the reasons why having high testosterone can lead to some of the metabolic problems in PCOS, like having high cholesterol. Testosterone has a direct impact on lipids, and so do estrogen. So these hormones play major roles in our lives. The small changes in testosterone that we see, for example, with a birth control pill, I would say in general are not going to impact overall health as much as they will probably impact in some ways sex drive as like the main thing that a woman might see.
Mm-hmm. And what about in terms of, I'm thinking, we haven't talked about fertility, but in this way, in terms of like treatment for fertility, but in terms of like, because obviously if you're on a birth control, you're not getting pregnant. So if you're looking, I want to skip first to the other considerations. You mentioned things like, heart health and cholesterol. So it sounds to me also like treatment for PCOS really should have also a long-term goal, meaning it's not just, I think many women just think about it as in terms of conception and hair growth, but you're also saying that there are medical implications of having untreated or undertreated PCOS in terms of the implications for heart issues or metabolic issues. Is that accurate?
Definitely, that's
Okay.
accurate. And I often tell my patients that getting a PCOS diagnosis, say in your 20s, it's challenging. And it means that you have this for life. It's not something that's ever going to go away. But it can also be an opportunity, because if you get this diagnosis in your 20s, you can make changes that will have impacts, through your 50s, 60s, and hopefully way beyond. Because men get metabolic syndrome too,
Mhm.
but a lot of times it's not found out until much later in life. And so as women, I would never say that PCOS is a gift, but if there's one silver lining in having a PCOS diagnosis is that we see it earlier because of the way that it affects a woman's periods. And because we see it earlier and can diagnose it earlier, then we actually can have an impact. So we can have a patient make changes in the way that they live their lives to hopefully help them be healthier as they hopefully grow into middle age and beyond.
And does it put them, assuming they make these changes, or most of the time, let's put it like that, perfectly imperfect, but most of the time they are eating things that have low glycemic index and higher quality foods, and they exercise, and they've been taking care of themselves. Are they still at this point higher risk for metabolic issues in their 50s, 60s, 70s? And is
So
that
they
something that they'll
will
need to be like addressing?
So they will still be at higher risk. And this is also an area of, I would say, burgeoning research. In terms of what does it mean if you can control PCOS earlier? How does that impact later cardiovascular health? So I don't know that we have perfect knowledge on this yet, but
Mhm.
we do know that women probably still are at risk. But the better controlled your insulin and other metabolic factors are earlier, the more likely you are to have a healthier later life.
Interesting. Interesting. Okay. And then I guess just coming back to the question of, how you treat this with fertility treatment, and what are the possibilities once, if somebody is able to do some level of, nutrition and exercise and metformin, what is the likelihood of them getting pregnant without increased intervention beyond that? What have you been noticing?
So that's a great question. And actually, a lot of women want that. They want to be able to do this on their own. So I think that I should be able to manage this. And it does work for some people. I would say, unfortunately, the minority of patients will this be something that they can entirely manage with diet and exercise for the context of getting pregnant. Um, but it does happen. I would say some patients, and the truth is, the patients that for whom that is successful probably don't reach my office because they probably
Mm,
don't need my help. Um, so, if that is where we do see in the literature that weight loss has an impact. So that's where we do see that about 5 to 10% body weight loss is typically sufficient to restore ovulation for most women.
wow.
So that's where that can be a motivating factor. But like I said, I don't necessarily tell that to my patients because that's not helpful to them.
Right.
That's like me
Right.
saying, go lose weight. How? Do you think that I've been trying to do that for the last 10 years, doctor? So I think
Exactly.
that's why we really just don't go there as much as saying, okay, we'll do what we can in terms of diet and exercise, but ultimately you might need my help to ovulate, and that's okay.
Okay. And I want to also clarify there are some women that don't have obesity as a part of their diagnosis, correct?
Correct. So there's many different types of PCOS, and there are many women who have PCOS without obesity. So typically they will still have insulin resistance. So the sugar problems are still there. The high testosterone is still there. The many follicles are still there, but obesity is not necessarily something that they're struggling with.
So meaning like if somebody maybe has irregular periods or doesn't, but the idea is that you can't say, well, it's not going to impact me because I'm not obese. Like then this is not my diagnosis. And finding out what it is you are actually dealing with is something, kind of, it's just, I think I agree with you. I think knowledge is very much powerful. Is this something that you feel is like, I guess it feels to me like this is a chronic diagnosis. Like once you have it, this is what you have. And is this a very, very big deal? Is this, how do we qualify it for people who have it? I think especially because like within the religious world, especially, it's a question of who do I tell and who do I not tell? And is this one of those diagnoses that feels like that we have to disclose this on shidduch date number 3, versus like this is just a medical thing that I have that I will be coping with, but with good care and good treatment, it shouldn't impact my fertility in the long run. Is that I mean, how do you qualify this?
That's a great question. I would definitely put PCOS in the category of chronic conditions. It is something that a woman can live with and hopefully live well with proper management. So I'd put it under the same category of diabetes, high blood pressure, high
Really?
cholesterol.
Hmm.
Um, so chronic conditions, and I don't know if those things get disclosed on shidduch dates or not,
Yeah, I can't
but
imagine anybody saying I have high cholesterol on shidduch dates, but definitely diabetes has always been seen as, oh, that, that would be like that would preclude some people from being willing to go into dating somebody with that. So it was interesting that you put it in as a similar kind of, into a similar category.
well, there's different types of diabetes. So maybe we should put a caveat on that. Type 1 is a lot more severe than type 2. So maybe you put it under the same category as pre-diabetes or
Okay, fine.
just people who are
I'll give it to you.
overweight or people who are overweight without PCOS. So I
Mhm.
think that it is a condition. It can affect fertility in the sense that a lot of times women will need help to conceive, but it is one of our most treatable conditions. So
Okay.
I would really hate to see somebody excluded as a potential shidduch just because they have PCOS. If
Okay.
we're going to do that, then we're going to really start to limit,
Quite a mess.
who's available. So I think
Yeah.
it is something that it's an easily treatable condition. It can wax and wane, depend on the situation, and it is, if someone's coming to see me for fertility reasons, if they have PCOS, that's one of the things I'm like, oh, I can help with that. I can treat that.
Okay. What percentage of women would you say that you've been treating for PCOS who are trying to conceive that really have been unable to get pregnant? How often do you see it as actually the reason?
So it's interesting. So we actually have a whole category of infertility diagnosis called unexplained, which is when we just don't know why. And about 40% of patients that we treat actually fall into that category. So if a woman with PCOS comes to me and we get her to ovulate and she's still not getting pregnant, and we check everything else, her fallopian tubes, ultrasound, maybe even a semen analysis, and she's still not getting pregnant, I actually would remove PCOS as the reason why she's not getting pregnant, and I would put her into the unexplained category.
Okay. Okay. So it would just be like anecdotal, the fact that she had PCOS and that there has to be something else that's contributing to the lack of conception. Interesting.
Correct, because somebody
Interesting.
with PCOS, if they're able to ovulate, in theory, they should be able to get pregnant. Now, I say in theory because it's sometimes harder than that,
Sure.
and there may be other contributing factors, but I would say it's a very treatable condition in that once patients ovulate, a majority of them will be able to conceive.
Okay. And I guess one other thing that comes up a lot when it comes to a PCOS diagnosis that I'm familiar with is the higher rate of miscarriage. Is that a truism? Is that something you notice? And can you help explain why?
So it is true. So women with PCOS are at higher rate of having miscarriages. We don't exactly know why. Um, my hypothesis is that it's probably due to that hormonal imbalance. So we know that there is a very, very fine balance of hormones needed for pregnancy maintenance. And when you don't have that balance completely correct, then that can lead to miscarriage. So it's not something that we know 100% why. But we do know, and I see this in my practice, that when we work on restoring that balance, specifically trying to have a more normal testosterone production, and again, with some of those issues that we talked about, that can ultimately lead to healthy pregnancy. But we don't always know why patients with PCOS have miscarriage.
Because there's no way to like maintain a normal testosterone balance in pregnancy specifically, other than diet and exercise, right?
No, and I would say that's a question I get asked a lot by my PCOS patients. How can I lower my testosterone levels? I know
Right.
that my testosterone levels are high. How can I lower them? There's really only two answers. One, if you don't want to get pregnant, go on a medication like a birth control pill. Metformin can lower testosterone levels by restoring that insulin balance. But then the second is really just exercise and diet, and
Mhm.
diet being the key there is, not letting your body have those insulin spikes, which is going to cause the higher testosterone production.
Okay, which I guess could be one of the only options available for somebody who's already pregnant to try to help maintain a lower testosterone levels during pregnancy is really only diet. They're not going on birth control pills. So,
Exactly. And there
mhm.
are some diabetes medications that are safe in pregnancy. So, one of the things, women with PCOS are definitely at higher risk of having something called gestational diabetes, which is diabetes in pregnancy. So, we do recommend that women with PCOS have early testing for diabetes in pregnancy and then treatment if indicated.
Interesting. Um, okay, so is there any question that I have not asked you that you would hey, you didn't cover this point when it comes to PCOS or anything that I've missed? that you think that you really want to make sure people understand?
So the one thing that I would say we haven't talked about yet is management of someone who wants to get pregnant. So we talked a lot about if you don't want to get pregnant. If you do want to get pregnant, I still start with the lifestyle modifications. But like I mentioned, often medication is needed. And fortunately, we have very effective medications for what we call ovulation induction. So we have two general classes of medications. One is called clomiphene citrate. The other is letrozole. They are both medications that are pills, so they're taken orally, typically 5 days a month, and they are very effective in getting a woman to ovulate. Now, when I say very, not every woman will respond to these medications,
Right, right.
but for women who do, it helps the brain send that hormonal signal to the ovary so it works to get that woman to ovulate. And it only works in the month that it's taken. So you have to take it every month that you want to ovulate. But that can be a very, very effective treatment. And if that doesn't work, then we move on to some of our more aggressive treatments. Fertility injections is something that we do have an option for, not used as much because it increases the risk of twins and triplets pretty significantly. And then IVF, which we mentioned before, can be a very effective treatment for PCOS if those lower intervention treatments don't work.
And the one thing I have to mention, just as a PSA, public service announcement, if you're taking Clomid, that clomiphene that you just mentioned, that if you take Clomid, I just need to put a plug in there. Please make sure you're doing it monitored. Like I have to recommend based on my experience, like unfortunately, there's a lot of physicians that will just give you some Clomid and not even watch what's going on, because it's seen as like such an effective, but also like low risk medication. I don't know how you feel about it, but I had a woman that I worked with who ended up with triplets, from unmonitored just Clomid. And I just want to recommend that if you're doing any of these medications, make sure you're being monitored by somebody who's an expert in this field rather than just winging it. Do you have any? You can totally disagree with me, but I'm curious to know your opinion.
Yeah, so any of these ovulation induction medications, unfortunately, so Clomid, which is the brand name for clomiphene citrate, or letrozole, increase the risk for multiple gestations. And we
Right.
quote about a 10% chance of having twins, about a 1% chance of triplets. So that is definitely a risk of these medications. There's different ways to monitor. So we can monitor with ovulatory progesterone levels. We can monitor with ultrasound. I do recommend that these medications are being prescribed by a physician who is able to counsel effectively about the risks of multiple gestation, and can adjust dosing if needed based on the individual situation for the patient. So
Right.
I agree that these medications are not to be given out without proper counseling and proper understanding of the implications.
Right. Okay. I do have to ask you just one quick question because it's going to stick with me and possibly some other people heard you say it. The idea of, and this is, I guess, maybe again, one step to the side, when you talk about the idea of not having a period, increasing the risk of endometrial cancers. Okay. How does that impact when you have so many women who are on things like the Mirena IUD or on continuous birth control and not getting a period? Is the association similar?
So that is such a great question. I get asked that question a lot by patients. So I really appreciate you asking it. So what happens if, and let's say, for example, PCOS, which we've been talking about, if you're not getting a regular period and it's because you're not ovulating, your body is still producing a hormone called called estrogen. So your body is producing estrogen, but without ovulating, you're not going to have regular exposure to a different hormone called progesterone. So estrogen builds up your uterine lining, progesterone organizes it. When progesterone goes away, you shed it. That's how you get a period. So normal endometrial function, now endometrium is the lining of the uterus, normal endometrial function needs both estrogen and progesterone. Too much estrogen and no progesterone, that's when you're at risk for endometrial cancer. So that can happen in PCOS if you don't get regular periods or you're not on some sort of hormonal treatment. Now, that's very different than someone who's on a birth control pill or who's on a progesterone IUD. That woman is getting constant progesterone exposure. So her uterine lining is protected and it's healthy, even if she's not getting a period at all. So women, for
Okay.
example, who take a Mirena IUD might not get a period for 3 years.
Right.
That is totally fine because her uterus is being exposed to progesterone. So she is not at risk of having endometrial cancer.
Do these Thank you for clarifying that. And is the Mirena and the continuous birth control pills providing only progesterone, or they're also supplementing estrogen as well?
So the
Estrogen pellets
IUD is a progesterone only
only.
medication. So,
Okay.
but because it's so interesting, but because the progesterone is mostly local in the uterus, it's not preventing the woman from producing her own estrogen.
Oh, interesting. Okay.
Yeah. So
Okay.
most women with an IUD will actually still ovulate most months. It's just that because the lining is so thin, you won't get a period.
Uh-huh. And
And
so
a birth
birth control
control
pill?
pill, yeah. So most both birth control pills actually have both estrogen and progesterone components.
Right.
There are some birth control pills that are progesterone only. An example of that is something called the mini pill. And
Mhm.
there's actually one that just got approved for over-the-counter use that is going to be
Right. I did hear
progesterone
about
only.
that.
Yeah.
Yeah. Right. And those will probably not, but those, will those work in terms of stopping a period? Or we're using mostly, isn't the mini pill more like typically used for breastfeeding parents?
Correct. So the mini pill
Okay.
typically does not prevent ovulation,
Okay.
but it does. Some women are more sensitive to it than others, but many women will still get a regular period on a progesterone only pill like that.
Okay. Okay. So interesting. I mean, I just find that the conversation around hormones, we talk about hormones so much in terms of mental health and then just understanding the complexities of physical health. We didn't even get into the conversation or why it is that PCOS has a higher increased risk of depression and anxiety, but we'll have to address that another time. But let me just let's close today with your top 2 or 3 misconceptions that you want to make sure people know about.
Thank you. And it's been such a pleasure talking with you. I really hope that anybody listening to this will feel empowered about their knowledge of PCOS, and maybe you'll even apply to you in terms of being able to feel more in control of your body. So the things that I find to be the biggest misconceptions of PCOS, one is just the name. That everyone associates PCOS with ovarian cysts, and that's just not true. Like we talked about, it's really not about having cysts, it's about having lots of eggs or follicles in the ovaries. Another misconception that I see a lot is women come to see me and they're like, I can't get pregnant because I have PCOS.
Mhm.
And as we talked about, PCOS is a chronic condition. Yes, it can impact fertility, it can make it harder to ovulate, but you can still get pregnant. So don't think that PCOS is a natural form of birth control.
Ooh,
So
good
there are
point.
many women that will ovulate maybe once every 3 months. So they're like, oh, I'm not getting regular periods. I won't get pregnant. I would say that's not true. It can be challenging. So I don't want to negate that, but it's not a diagnosis of infertility itself.
Oh, I love that. Okay.
Yeah.
Well, thank you, Dr. Wienerman. This is Rachel. This has been amazing. This is such a wonderful hour packed with so much content and knowledge. And I know that I love the way that you flip the conversation around kind of what we put in our body in terms of keeping us healthy and women feeling empowered to take control if they can. And to just kind of change the conversation a little bit. But mostly this was just so full of information. So thank you. This was great.
Thank you so much.